It's a pleasure to introduce Tom Newson-Davis, Rohit Lal, and James Spicer to discuss the latest developments in lung cancer.
So I'm going to discuss three trials. I'm going to discuss Point Break, which is abstract number 8004. I'm going to discuss Pronounce, which is the late-breaking abstract 8003, and I'm going to discuss Avapearl, which is the abstract 8014. Now, these are all trials and presentations which are investigating the use and the role of Avastin in first-line treatment of advanced non-small cell lung cancer, and in particular its relevance in modern therapies, which are pemetrexed-based often and maintenance-based as well. It might be worth just remembering what we know already. Well, we know from ECOG 4599, which is a trial that came out back in 2006, that if you add Avastin or bevacizumab to paclitaxel and carboplatin, you increase overall survival and progression-free survival. But we also know from a trial 3 years later in 2009, which was the AVAIL study, that if you add Avastin to gemcitabine and carboplatin, there's no improvement in overall survival and PFS. There are some outstanding questions which these trials have attempted to understand. We don't know really whether, when you're treating first-line lung cancer in the advanced setting, whether the induction combination chemotherapy should include Avastin or not. In other words, should we be using doublet or should we be using triplet chemotherapies in that setting? We also don't really know whether a pemetrexed-based or a paclitaxel-based regimen is the best, or whether in fact they're equivalent. We also don't really know the old question of whether cisplatin and carboplatin are equivalent, or whether in fact one may be superior to the other. And finally, when it comes to the maintenance setting, we're not entirely certain whether bevacizumab is the way forward, pemetrexed is the way forward, or whether in fact we should use a combination of the two in that maintenance setting. So these three trials are attempting to go some way to understanding and answering these problems. The first trial I'm going to discuss is Point Break. Point Break is a study which actually some of the data and survival data was presented last year. It is a study which is comparing pemetrexed, carboplatin, and bevacizumab induction for 4 cycles, followed by pemetrexed and bevacizumab maintenance. And that regimen is compared to paclitaxel, carboplatin, and bevacizumab with bevacizumab maintenance. It's actually a negative study. There's no significant difference in the primary endpoint, that was overall survival. In the pemetrexed-based arm, that was 12.6 months, and in the paclitaxel-based arm, it was 13.4 months. There was a statistically significant improvement in progression-free survival, which was increased from 5.6 months in the paclitaxel-based arm to 6 months in the pemetrexed-based arm. And although that statistical significance was lost in the older age group over the age of 70, what was found was that in terms of safety, it was still safe to give this regimen in all age groups. So what can we learn about this study? Well, there were a couple of issues raised in it, one of which is that an insufficient number of deaths had occurred in the maintenance part of the trial, which may hamper our ability to interpret the progression-free survival and overall survival data from that. There were sufficient deaths in the induction arm, so that data is probably sound. So what can we conclude? Well, we can conclude that you can use either regimen in the induction setting. So in other words, you can use a carbotaxol Avastin, or you can use pem-carbo Avastin, and they're probably about the same. It'd be interesting to see what the more mature data, maybe next year or the year after, in terms of the maintenance data, may throw up. The next trial to discuss is called Pronounce. The Pronounce study compared pemetrexed and carboplatin induction with pemetrexed maintenance, which is very much what people might be doing in the UK, and they're comparing that with paclitaxel, carboplatin, and Avastin with Avastin-only maintenance. What this study showed was there was no statistical significance in overall survival or progression-free survival. The overall survival in the pemetrexed arm was 10.5 months, and the overall survival in the paclitaxel arm was 11.7 months. This is a smaller trial than Point Break, 150-odd patients in each arm, and therefore it's a little bit difficult to be too certain about the significance of the findings. But I think it suggests that just pemetrexed carboplatin is equivalent to carbotaxol and Avastin. And I think that's quite helpful for us in the UK, where, as we know, Avastin is not available either through NICE, and is currently not available through the Cancer Drugs Fund either. It's also probably a helpful piece of information for patients who can't receive pemetrexed, because if you can't receive pemetrexed and you can get access to Avastin, then it's reasonable to give carbotaxol Avastin. One issue raised with PRONOUNCE was they had a rather unusual primary endpoint, which was grade 4 progression-free survival, and that was a subject of much discussion as to whether that slightly unusual endpoint was particularly helpful. You may have noticed so far that all those trials are carboplatin-based trials, and pemetrexed is very much the standard of care in adenocarcinomas, but the license is with cisplatin. Only one trial in all of this has investigated the role of Avastin in combination with pemetrexed in cisplatin, and that's the AVAPERL study that produced some immature data last year. That was the overall survival data wasn't ready, and they presented their updated survival data this year. AVAPERL is comparing pemetrexed, cisplatin, and Avastin, going on to pemetrexed and Avastin maintenance, and comparing that combination with pemetrexed, cisplatin, and Avastin, going on to Avastin maintenance. There was a statistically significant improvement in progression-free survival, and that was a primary endpoint. It was increased from 6.6 months to 10.2 months in the pemetrexed-based arm. There was also an improvement in overall survival from 15.9 months in the PEM-cis-Avastin arm to 19.8 months in the PEM-cis-bevacizumab going on to pemetrexed-Avastin arm. That was not statistically significant, however. That does raise some interesting things. So you could argue, therefore, in this trial that because it's a non-significant improvement in overall survival, that combination is not terribly helpful, and we shouldn't be using pemetrexed and bevacizumab maintenance. Or you could look at a different way. You could say, well, the overall survival is actually 19.8 months, almost 20 months. And this is the first time that any trial has shown overall survival in the first-line setting of over a year and a half. You can compare that to the Paramount study, which people may remember was PEM-CIS followed by pemetrexed maintenance, and the overall survival there was 16.9 months. Now, cross-trial comparison is a fraught process, but one possible interpretation of this is that if you do have access to Avastin, the way to do it is to combine it with pemetrexed and cisplatin and make sure that you give your maintenance therapy containing both pemetrexed and the Avastin. So, in conclusion, what do we know now that we didn't know before? Well, the water's a little bit more muddied, in fact, and we don't have any clear answers as ever. But I think we can conclude a couple of things. I think we can conclude that in the induction phase, pemetrexed, carboplatin, and bevacizumab are probably about the same as carbotaxol and bevacizumab. We can also probably conclude that carbotaxol is the same as, that pemetrexed and carboplatin is the same as carbotaxol and Avastin. It may suggest that cisplatin-based regimens are better and more effective than carboplatin-based regimens, although that's not confirmed. And it would suggest that if you're going to go for maintenance therapy, using Avastin only as a maintenance is probably under-treating the patients, and they should be getting pemetrexed maintenance somewhere in their treatment regimen.
So, Tom, the primary endpoint in this PRONOUNCE trial was unconventional, shall we say, grade 4 PFS. I think in the session yesterday, the presenter made the point that this was suitable for comparing two therapies which were expected to be similar in efficacy. So it's introducing a tolerability component. What are we to make of it?
Yeah, it's a difficult one. I think it was a novel endpoint for most of us in the audience, and my understanding is it's a endpoint that looks at the development of any grade 4 toxicity or progression. And that is your endpoint. The criticism raised in the hall was that it was any grade 4 toxicity. Now, there are some grade 4 toxicities which are clearly extremely important, and you would want to discontinue a trial of grade 4 diarrhea, for example, grade 4 mucositis. But it would also therefore include some grade 4 hematological toxicities, which, although problematic and may cause some dose reductions or maybe delays in treatment, may not itself be a reason to stop treatment. And so for that reason, it was felt to be perhaps make the interpretation of the data a little bit difficult. The other thing people picked up on was that although this trial was trying to, by using a G4 PFS, focus on quality of life, there was actually no formal quality of life assessment in the trial. There were no standardized quality of life questionnaires, and so the quality of life data perhaps was slightly missing in this trial, although it seemed to be maybe the main plan behind it.
Yes, I mean, quite a significant omission, perhaps many might say. I mean, even the presenter admitted, I think, that this particular endpoint in future trials would probably need further modification. Probably also worth pointing out, isn't it, that there's no suggestion that patients came off therapy if they had a grade 4 toxicity. It was just that the censoring of the endpoint, if you like, was either at grade 4 toxicity or at progression.
Yes.
Do you think the quality of life data has been reported fully for these combinations?
So there's a difference in quality of life and difference in side effect profile. So we know that taxane-based regimens will make your hair fall out and they'll give you paresthesia, which are the two patient-reported outcomes which are the most problematic. Whereas pemetrexed-based regimens will tend to cause more anemia, a little bit more thrombocytopenia. The quality of life data has been looked at in other studies but wasn't reported in PRONOUNCE and, as far as I know, wasn't reported in AVAPAL. There had been a suggestion previously in the early studies, particularly ECOG 4599, that Avastin-based regimens shouldn't be used in the elderly patients, by which they define as over 70. And that was one of the points of Point Break, was looking at the overall survival in relation to age groups. And they found that although the progression-free survival benefits were lost in terms of statistical significance if you're over 70, what was found was the drug was safe in all age groups. If I could ask one question back to James, perhaps. The majority of the data here is carboplatin-based, pemcarbo versus carbotaxol with or without Avastin, for example. Only one trial is with the licensed use of pemetrexed, which is with cisplatin. Do you think cisplatin and carboplatin are interchangeable in first-line lung cancer in the maintenance setting, given what we know now? Or do you feel that there is a difference between the two?
Well, I think in advanced disease in general, I think there's a consensus that it doesn't really matter which drug, and certainly the audit data suggests that carboplatin is very heavily used, more than cisplatin in combination with pemetrexed in the UK and in North America. In fact, there's pretty good data showing that that's the real world, and I think in the advanced setting that's accepted. Whether the maintenance is different from any other setting in the advanced disease, I would question. I mean, the only exception to all of this, of course, is in curative treatment, or where in the neoadjuvant setting where it's response that we want, then perhaps we ought to be keeping cisplatin at the top of our agenda.
And Rick, I'll ask you one question, which is, imagine the halcyon world whereby every drug is available. The Cancer Drugs Fund is replete with cash, and you can get any drug you want. A patient comes in, former status 0 or 1, advanced non-small cell lung cancer. Would you or would you not be giving them Avastin as part of their chemotherapy regimen? And would you be giving them a cis-based regimen? Would you be giving them pemetrexed? Would you be giving them taxanes? What would you do in the ideal world?
I think it's important to bear in mind that the AVAPAL study was negative, but what's really positive and very reassuring is the degree of the numerical value of the median overall survival.
Yeah.
And I think it's a huge...
19.8 months.
Absolutely. I think it's a huge development in a previously difficult to treat disease that we now have reported clinical trials with an overall survival advantage of that significant a number. And that does mean to me the value of the treatment is in continuing to disease progression, i.e. maintenance therapy.
Yeah.
The benefit of adding Avastin to a maintenance regimen is worth discussion, but is not something that I will push onto all of my patients.
And do we feel in the UK, where we don't have access to Avastin and we are by and large using the paramount regimen of PEM platinum and PEM maintenance, do we think we're under-treating our patients, or do we feel, in fact, they're getting as good a deal as patients in the United States, for example, who do have access to it?
I'm very, very reassured that the combination of cisplatin pemetrexed moving into pemetrexed maintenance is the best choice for my very fit PS01 patients.
Yeah, I don't think in the adjuvant, the maintenance setting, that we're missing anything without access to bevacizumab, and really we're not mandated to use it in the first line metastatic setting either. So I think either way we're in a comfortable position with bevacizumab. Tom.
At ASCO 2012, the Taylor study in second-line non-small cell lung cancer reported a statistically significant difference in progression-free survival in favor of patients receiving docetaxel. The study generated a degree of controversy as far as its trial design and its conduct, and raised the question of what is the best second-line agent in non-small cell lung cancer. And two studies that were reported at ASCO 2013 give us more information in this difficult-to-treat group. The first that I would tell you about is abstract 8006, the Delta study. This was a randomized phase 3 trial of erlotinib versus docetaxel as second or third line therapy in patients with advanced non-small cell lung cancer who are EGFR wild type in a Japanese population, and was a large trial with 301 patients who received erlotinib in the dosage that we're familiar with in the UK. However, their docetaxel dosage was 60 milligrams per meter squared, given every 3 weeks, which is a regional dose standard. The primary endpoint of the study was progression-free survival. And what the results showed were that for all of the patients who were within the study, the median progression-free survival for erlotinib was 2 months and docetaxel was 3.2 months, but the p-value of 0.092 showed that this was not a statistically significant difference. However, when the population is subgrouped according to the EGFR wild type expression, then the median progression-free survival is statistically different in favor of docetaxel, with 2.9 months progression-free survival in comparison to erlotinib of 1.3 months progression-free survival. This did not carry through to a statistically significant difference for median overall survival. And so this trial is a negative study, as erlotinib failed to show better progression-free survival over docetaxel. The second study that I would like to tell you about was a late-breaking abstract, 8005, the PROSE study, which was a randomized phase 3 study from a national Italian group using a proteomic stratification, that is a serum proteomic test called VeriStrat, to try to identify which patients may gain benefit on a particular agent in the second-line setting. So again, a reasonably sized trial with 285 patients who were stratified according to their performance status, their smoking history, and the pre-treatment VeriStrat test, of which the results were blinded to the investigators, allocated to 2 arms, standard dose erlotinib, or the investigator's choice of standard dose pemetrexed or docetaxel, and I suspect that was based on the histology of the patients. The primary endpoint was overall survival, and the primary hypothesis was that there's a significant interaction between VeriStrat status and treatment. And the results showed that 263 patients included in the protocol primary analysis, 68% of patients in the chemotherapy arm and 72% in the erlotinib arm were classified as Veristrat good. The primary objective of significant interaction between treatment and Veristrat classification was met with a statistically significant p-value. For patients who were reported as Veristrat poor group, these patients performed worse on erlotinib compared to second-line chemotherapy. There was no significant difference in overall survival between the treatments in the Veristrat good group. That is, that there was no difference between receiving chemotherapy or erlotinib if your Veristrat score was favourable. And so the results suggest that the Veristrat status is predictive of the differential overall survival benefit for erlotinib versus chemotherapy in the second-line setting. The results complement previous analysis from BR21, where the prognostic behaviour as Veristrat was established, and this is the first study suggesting a predictive value for Veristrat, and confirmatory trials are awaited, in particular a large European-based clinical trial from ETOP. Thank you. Thank you for joining me to discuss these clinical trials, which are very relevant to UK practice. You're aware that NICE will review its guidance on the use of second-line agents in non-small cell lung cancer. Do we feel that the Taylor study has redeemed itself with the Delta study reporting much the same results?
Yeah, I think, can I start, Tom? I think Taylor started something which we've seen not finished, but certainly followed up at this ASCO. So Taylor, just to remind everybody, was a second-line study in mutation wild-type patients randomized to docetaxel or erlotinib, so a lot in common with the two trials that Rose just told us about. This is a very real, everyday clinic conversation that we have between ourselves. A patient who's had first-line chemotherapy has a known EGFR mutation status, which is wild-type, which is the best treatment, chemotherapy or TKI. So now we have quite a lot more information with Taylor last year and these two studies this time around to answer that question. And in my mind, being completely ambivalent has to be reviewed. I think there is now a real suggestion that there may be some benefits to docetaxel, at least from an efficacy point of view. Of course, especially in the second-line setting with advanced non-small cell lung cancer, we've got to put that in the context of tolerability, toxicity. So we've got a clear conflict between a drug which is perhaps a bit more efficacious and a drug which is perhaps a bit more tolerated. What we really need is a way of determining which are the patients who are perhaps going to be disadvantaged by erlotinib, relatively advantaged by chemotherapy, and that's perhaps where Veristrat comes in, which has been long discussed at many years of meetings with lots of preclinical data and retrospective analyses until now. And as you pointed out, this is the first prospective exploration of whether Veristrat is predictive in this setting.
So Tom, do you think that using Veristrat will help you identify which agent would be your treatment of choice for a well PS01 second-line patient?
I think it would help. I think there are a couple of things to point out, one of which is that neither of these drugs are great. Their drugs are very limited effect. They're not a cure, they're not a panacea, but you do want to make sure that you get the right one. And as James mentioned, docetaxel is a drug with a significant side effect profile and in an unwell population, and when that toxicity profile is often myelosuppression, it is a drug to be given only to the right patient. Erlotinib, however, is much more expensive, and you want to make sure if you are giving that, you're giving it to someone who it is going to benefit. The question is whether you really need Veristrat to tell you. If you look, the way the Veristrat works is it looks at a whole lot of mass spec peaks from the serum, and those were taken from patients who responded well to treatment, and those peaks are characteristic of those patients. We don't actually know what those peaks are. We don't really know what the significance of this mass spec finding is. It just correlates very well with it. But if you look at the Veristrat good population, they tend to be younger, female, have non-squamous cancers. And those are the ones who you can give either to. But we probably know that already. We know that just from clinical sense. If someone's younger, female, and doing well anyway, you probably know they're going to do better and you can give them any treatment. The question is whether you need the Veristrat to confirm that. I think that as the financial implications of having alotinib against a generic drug like docetaxel continue to increase, the removal supposedly of alotinib from NICE and its transfer onto the Cancer Drugs Fund, maybe using Veristrat and paying a few £100s for that to allow you to make a scientific decision about what you should and shouldn't use. Maybe that will be the way forward.
It's worth adding that good performance status and smoking history was also statistically significant for the Veristrat good group.
What we really need, of course, as Tom was alluding to, is to begin to dissect out what's in Veristrat. You know, if we had a little straightforward proteomic profile that we could use that was a little bit cheaper than sending your sample to a mass spec lab, then we really might be onto something which the NHS could scale up. But that's many steps away. And you know, as has been pointed out already, what we need first is a confirmatory trial just to see whether this is real. As we've said already, this is the very first prospective validation of a whole new approach. So it's just the beginning.
I guess one other question is whether the NHS will pay for Veristrat. Already trying to do your EGFR testing or AMP genotyping, these are all costing money, and if we're going to go down another cost, you may maybe require NICE approval to even send the test off. I don't know how much it's going to be, but it won't be free.